Dear ladies and gentlemen, dear course directors, thank you very much for giving me the opportunity to talk to you about this probably most challenging title that I've been given so far, Cardiac MR from Physics to Clinic in 20 minutes. That's impossible, so I'll try and do my best. So what I thought I'd do is I'd sort of spend a minute or so on physics, what I think you need to know, and then talk a little bit about the different techniques that we have in cardiac MR, just to give you an overview of what might be relevant for you as an interventional cardiologist. And then I'll give you a little bit of an example where you can use cardiac MR in interventional cardiology relevant trials. And then I'll give sort of conclude with where is cardiac MR in the clinical world, really, in terms of diagnostic. So in a nutshell, physics. And I'll read this to you because I couldn't explain it as well in my own words if I tried to formulate it to you. So MRI uses hydrogen atoms in the body to generate an image. When these hydrogen atoms are placed in a very strong magnetic field, and magnets that we use of 1.5 Tesla are seriously strong, then these atoms basically align themselves in the direction of the field. And then we use a radio wave, essentially, which we apply, which delivers energy to these atoms. And that causes these atoms to align in a slightly different direction, or some of these atoms in a different direction. And when the RF pulse is then removed, the atoms return to their resting state, thereby releasing some energy which we can pick up. That signal we pick up. And that is still a very complex process, but we basically turn those signals into the images. So I think that's really the shortest description of MR physics, but I think it's not really relevant to interventional cardiologists to have much more of a grasp of the MR physics. So as I mentioned, the title was From Physics to Clinic, but I think there's a lot in between research, and I use the research aspect to guide you through the different techniques that we have, and then to give you an example of how we can use cardiac MR in research. So I think what's relevant to interventional cardiologists is how we can use cardiac MR to make diagnoses, to assess prognosis, to guide management decisions, to monitor treatment effects. And you may also be interested in thinking about how can we use cardiac MR in clinical trials to test for novel therapies, so using cardiac MR as a surrogate imaging endpoint. Now, this is an overview of requirements to have a very, very good imaging surrogate endpoint in clinical trials. And this is really just to give you a little bit of an overview of the CMR technique. We need to know how accurate the technique is. We need to know how reproducible the technique is. And then there are some inherent cardiac MR features which we are very happy with. The fact that we can usually repeat the technique because it's non-invasive, doesn't use radiation. But we do have to bear in mind, particularly in interventional cardiology, some of the pathology that we're imaging has got a dynamic changes over time, for example, infarct size or myocardial edema. So that sort of limits us somewhat in terms of saying that we can repeat the image technique many, many times and get the same result. Often, and I'll give you at least one example today, MRI is very, very novel, and there are no other techniques to provide you non-invasively the information that MRI can provide. So that's very exciting if we distinguish CMR from other imaging modalities. And then the key things to make a good surrogate imaging endpoint is really that we know that the imaging surrogate endpoint correlates with prognosis. The next step is that we know if we intervene with a novel medication that we can change the imaging surrogate marker, but that also then changes ultimately the prognosis of the patient. And that's where cardiac MR really hasn't got a lot of data on, but hopefully in the next 5 to 10 years we'll have lots of data. Hopefully. So let's talk through the different imaging modalities that might be of relevance to an interventional cardiologist. And first of all, the non-contrast techniques. This is the bread and butter, really, of clinical cardiac MR. We acquire short-axis cines, and that allows us to measure left and right ventricular volumes. And Carrie Davis in the audience here was one of the co-authors on a very, very frequently cited paper, which basically compares the reproducibility of echo and cardiac MR, demonstrating that if we want to test a new medication and the effect, let's say, on left ventricular mass, so a new antihypertensive medication, we want to be able to pick up a 13-gram change of left ventricular mass reduction due to this medication. We can reduce our sample size to 3% of what we would have to do if we used sort of native 2D echocardiography, and that's purely based on the high reproducibility of the technique. We get a lot of information with these standard sequences, global parameters both for left and right ventricular mass, volumes, function, but we also get segmental parameters like wall thickening, end systolic wall thickness, end diastolic wall thickness. And we get dynamic parameters, peak ejection rate, time of peak ejection rate, and the similar sort of diastolic filling rates. Now, this is really an appraisal of the sort of how good is cine imaging, cardiac imaging, in terms of being a surrogate endpoint. And you can see that it's highly accurate, highly reproducible. It's frequently abnormal if you have a diseased heart. It can be acquired in all subjects. It's not really novel because echo can give you similar information. Correlation to prognosis surrogate markers has been established, and we know if we intervene, this leads to a change in surrogate endpoints. Now, contrast techniques really I want to split into two, and the first one is to look at perfusion imaging, and that's what we often call first-pass perfusion, and we'll hear the diagnostic sort of accuracy from Jörg Schwitter later on. But really what this is based on is the gadolinium contrast uptake in normal myocardium is very, very quick. And in ischemic myocardium, this is delayed and the amplitude is much smaller. So what we really look at in the first 10 seconds during the first pass is a difference in signal or gadolinium concentration between normal and ischemic myocardium. And this is what you can see here. In a patient during adenosine stress, you can see this perfusion defect, the sort of slower uptake of contrast in the anterior wall as compared to rest. So you've got a reversible perfusion defect here, and we can visually assess this. But as Frank Rademacher said, it's often important to get some quantitative, which is still pretty much a research tool at the moment, but you can get some semi-quantitative information as well fairly easily. Now, where is cardiac MR perfusion in this imaging surrogate marker slide? You can see a lot of ticks for reproducibility, accuracy, etc. And we have prognostic information, which will be shown later on, I'm sure. Now, the second bit of contrast, so once we've given the contrast, we can actually wait for 10 to 20 minutes, or maybe slightly earlier if we give slightly less contrast. And that's what I'm sure you're all familiar with, is the late gadolinium enhancement technique. Now, this is based on the fact that an infarcted area has a slower uptake, but has a sort of contains the contrast for longer because of increased interstitial space, whereas normal myocardium has washed out the contrast already. So again, at this time, we can look at the difference in contrast uptake. So enhancing areas will be the infarcted areas, and there's some very, very convincing animal work from Ray Kim and Robert Judd, demonstrating really how well the late enhancement technique matches with histology in a dog model with infarcts. So basically, this led to the conclusion that bright is dead, and that normal stunned and hibernating myocardium is dark. So, and this, because of the accuracy and precision of this, we can actually calculate the scar in percent or in grams. Again, for this, a lot of ticks on this box, so we now have prognostic data for late gadolinium enhancement as well. So this is a very novel technique, or what I meant by unique technique, which hardly any other technique, or in fact no other technique, I think can provide, and that's the area of salvageable or salvaged myocardium, which basically uses the late gadolinium enhancement technique, measuring the area of necrosis, but we can use a T2-weighted imaging sequence, which allows us to image the myocardial edema in the acute phase after a heart attack, for example, and taking the difference between the two tells you something about salvaged myocardium, which is an interesting surrogate imaging endpoint if you want to test novel medications in the setting of an ST elevation MI, novel stents, novel medications like abciximab, etc. So again, here we've got quite a few ticks. The problem is that because the myocardial edema changes over the first few weeks after a heart attack, disappears and gets smaller, it's not really a very repeatable technique. And that's where we still struggle to know what is the best time point for actually doing these T2 weighted images following a heart attack to calculate the salvaged myocardium. Now I want to give you an overview of how you can use cardiac MR and the techniques I've just shown you to understand, get some more insights into interventional cardiology treatments. So this is a study that Joseph Salviner-Jaeger in Oxford, and I contributed to this work, undertook in patients planned to undergo a complex PCI. And basically 48 patients underwent this, had an MRI scan at baseline before the procedure, and this is an example where you see that all is dark, so there's no myocardial infarction in this patient before the PCI. Now, this patient had 3 long stents fitted into the LAD, and then following this stenting had another MRI scan showing some enhancement in this area here, demonstrating that there are cases that have new late enhancement following complex PCI. And in those 48 patients that underwent complex PCI, a surprisingly high number, so 29% of those patients had new late gadolinium enhancement. And if you look at those patients that had late enhancement, it actually equated to about 5% of the left ventricular mass. Now, what we observed in this study was, or this is a sort of a follow-up study based on some of the findings, was we observed that there are 2 types of late enhancement. One is distal to the stent implantation, so further apical in the myocardium, and some late enhancement is actually next to the stents, at the level of the stents. And this was sort of in about half and half we saw one pattern. And what we felt was that probably side branch occlusion is a mechanism and distal embolization is a mechanism. So Italo Porto in Oxford looked at this in more detail. So this is a patient who had a right coronary artery stenosis, and on IVUS you can see, and I'm sure you're all familiar with this, you can see the inner border of the vessel and the outer border of the vessel, and all of this is plaque volume. And you can see there's lots of plaque volume in this territory. You can see that the patient did not have any infarct, but then following PCI and stenting, you can now see that this red inner border has been pushed outwards and a lot of plaque volume has disappeared. And the patient has, in the apical segments, got new late enhancement equating to 2 grams. Now, if you plot the plaque volume change between baseline and post-PCI, you can see that in those patients who had a distal new area of late enhancement, the plaque volume changed massively. And that suggests that probably this is due to distal embolization. Whereas if you had no new late enhancement, then the plaque volume didn't change. And if you had this adjacent pattern, the plaque volume didn't change, suggesting that this probably is side branch occlusion. So these were really our conclusions. So this is an example of how cardiac MR can shed some new insights into the mechanisms of the damage that can be done using complex PCI. Now, moving on to where we are in terms of clinical use of cardiac MR, and the techniques I've showed you with cine imaging, perfusion, stress perfusion, and late enhancement really have been acknowledged now in the new NICE guidance for stable chest pain, which Adam Timmis was heavily involved with. And as you can see, particularly in the intermediate pretest probability, non-invasive functional imaging is the first-line technique. And obviously, you've got dobutamine stress echo, you've got nuclear techniques, but cardiac MR with perfusion definitely falls into this area. But you can also possibly offer it in the low CAD group if the cardiac CT maybe is uncertain, or you can offer it even in the high pretest probability population if, for example, there's a good reason why invasive coronary angiography is not appropriate as a first-line treatment. Or what we also have very, very frequently as a referral reason at the London Chest Hospital is this, that patients have had an invasive coronary angiogram and the severity of the lesion is somewhat unclear whether it's functionally relevant, and then we do a stress perfusion scan to see where the perfusion defect is or if there is any. Now, in conclusion, CMR physics is complex, and I think intervention cardiologists don't need to know much about it. The important thing is that CMR is non-invasive, doesn't use radiation, and is very, very versatile. For diagnosis, we know that for most of these techniques, it's highly accurate, reproducible, and sensitivity and specificity in the context of coronary artery disease is extremely high, and we'll hear more about this later on. In terms of prognostic relevance, we know that left ventricular mass, left ventricular volumes, late gadolinium enhancement, microvascular obstruction, which I haven't mentioned before, and perfusion all have prognostic relevance. We know that cardiac MR can guide management decisions, and as you've seen, clinical trials using CMR's endpoints might be extremely interesting to save costs or as an intermediate step before you do long-term outcome studies, which are extremely expensive because you need huge numbers and long-term follow-up. And with this, I'd like to thank all of you for your attention and all my colleagues at the London Chest Hospital.